All right, so we'll continue with our discussion of airway diseases. So starting with this chest radiograph, what looks abnormal?
There's a lucency under the heart.
Under what?
Under the heart.
Okay, so you can see this lucency here. So what do we call this? This is a particular sign. What's it called?
The continuous diaphragm
Yeah,
sign?
so this is the continuous diaphragm sign, right? Usually you don't see the diaphragm like this all the way underneath the heart. So there are three causes of a continuous diaphragm sign. What are the three causes?
Pneumomediastinum.
Pneumomediastinum is one. What's two? No, that doesn't give you a continuous diaphragm. Pneumoperitoneum is two. And number three, where else would the air be that might give you a continuous diaphragm?
Pneumopericardium.
Pneumopericardium, right. So those are the three causes of continuous diaphragm sign. For this patient, which of those would you favor?
Pneumomediastinum.
Why?
There's also a lucency around the neck as well.
Yeah, so there's lucency up here in the right paratracheal region. So here you would consider pneumomediastinum. What are causes of pneumomediastinum?
Esophageal perforation.
Sure, so esophageal perforation, if that's spontaneous, we call it Borjas from vomiting. What are other causes of pneumomediastinum?
Barotrauma from.
Yeah, so the most common causes of pneumomediastinum are barotrauma, right? So what are some of those common causes of barotrauma that can result in pneumomediastinum?
Intubation, overly increased pressures through intubation.
Yeah, so in an intubated patient, right, so that can happen from increased airway pressures and patients are intubated, but this patient's not intubated. So what might account for barotrauma in patients who are not intubated? What underlying condition?
Asthma?
Sure. So patients who are asthmatic, they might present with they have high airway pressures, that they might leak some air into the mediastinum, and they might present with spontaneous pneumomediastinum in the emergency room. There are other things that have also been associated with that, sneezing, coughing, etc., that suddenly increase airway pressures can also result in spontaneous pneumomediastinum. Okay. And then here's the lateral view showing you some air here along the mediastinum. This case is fairly slow for pneumomediastinum. If you think about it, it's an easy diagnosis with CT. We just look for air tracking around the mediastinal fascial planes, okay? Then the air going up into the neck accounts for the crepitus that they can often, the patients often have on physical examination when they have pneumomediastinum. So here's another example. So here you can see the air extending up into the soft tissues of the neck, here in the supraclavicular soft tissues, a little bit of lucency there around the heart, also around the mediastinum. And in this case, it's a little bit more obvious on the lateral view. You can see the streaks of air tracking along the anterior mediastinum. These patients were all asthmatics who presented in the emergency room with spontaneous pneumomediastinum. Okay? And again, very easy diagnosis. On CT, we can demonstrate the air pretty easily. All right, so for this patient, what are the findings on the chest radiograph? Well, what do you think that is? Yeah, I mean, there's a large opacity here, right? Yeah, okay. What is it?
Mm-hmm.
Well, you're gonna have to tell me what you think it is and why. First of all, is there any other finding that concerns you?
There's like subcutaneous air.
Yeah, so there's air here, right?
Yeah.
So what else would you be looking for in the chest? If you see that, you might look for what?
Pneumomediastinum.
Or, is there pneumomediastinum, first of all? Does the patient have pneumomediastinum? Yes or no?
Oh,
We vote no?
I vote no.
Rest of you agree, no pneumomediastinum here?
Looks like there's maybe some lucency.
Well, what about this stuff, right? So there are these streaks of air here extending up into the neck. So does the patient have pneumomediastinum?
Yes.
Yes. What else would you look for?
Mediastinal shift.
What do you think that opacity is on the left side? What could it be? Ma'am, you said it could be what? Well, do you think it's an effusion, yes or no?
I think it's more likely confusion because the heart is not shifted to the right.
Do you see the line?
Yeah, you see.
So what do you think you're looking at? All right, so how about we look carefully? Do we see this curved line here?
Yeah.
What is that? Why is it more lucent up here than it is here? There's a pleural line here. Look at the shape of this as it comes up, right? So what does the patient have? This is a large hydropneumothorax, right? So there's a large hydropneumothorax here, and there is pneumomediastinum also extending up into subcutaneous tissues. I'm telling you, there's no trauma. What could this be from?
Esophageal perforation.
From what?
Vomiting.
So this is a case of
Boerhaave syndrome.
This is a case of Boerhaave's. This is after oral contrast was administered. You can see the contrast actually leaking out into the pleural space. There's a large pleural effusion, and then all of this is pneumomediastinum. So that chest radiograph is a chest radiograph on a patient with Boerhaave's. Okay? Boerhaave's often is associated with left pleural effusion in addition to pneumomediastinum. So pneumomediastinum here, when it outlines next to the heart, is pretty easy to see when we see that on the frontal view. Can be subtle sometimes, so pneumomediastinum gives you a line like this because you have air in the mediastinum, air in the lung outlining the frontal planes there next to the aortic knob. Now, there are many causes of pneumomediastinum. Many of them are related to barotrauma, and so some of these, they're in your handout. You can review them all. This patient with asthma, you can see the air actually tracking around along the left pulmonary artery. This is called the ring around the pulmonary artery sign of pneumomediastinum because it actually tracks around the pulmonary artery as it's coming out. Another case of perforation of the esophagus with air here in the mediastinum, esophagus. This is a case of trauma. So you can see the laceration here of the trachea resulting in all of this air leaking out there. Okay, central bronchus. By the way, with airway injury, what is the sign on CT when you have a big pneumothorax that there might be an underlying rupture of an airway? What do we call the sign? Notice how this lung is way down there, right? What is that called? No, that's for ruptured diaphragm. This is the fallen lung sign. Right, so fallen lung sign if there's a laceration in the airway. Okay. Because the airways are the only things that hold the lung up in the mediastinum, right? The vessels are floppy. So if an airway is torn, if it's ruptured through, then the lung will fall down. That's the fallen lung sign. What's abnormal here? Right, so there's complete opacification of left hemithorax. So when the term for this is, what do we call, what's the term that they use when there's complete opacification of the hemithorax? It's called what?
A whiteout.
Whiteout, yeah. Two major causes of whiteout are?
ARDS.
No, ARDS is bilateral. No. Yes, so atelectasis Complete lung atelectasis versus large pleural effusion. Those are the two things you have to decide between when you have a case of whiteout. So how do you decide which it is? Okay, so in this case, what do we have? All right, so here you would suspect what then? Mucus plugging of, yeah, so mucus plugging of the left main bronchus resulting in complete left lung collapse, and the mediastinum is shifted to that side. The heart's also shifted to that side, that's why you don't see the right heart border, okay? So this is after sucking out the mucus plug, the lung expands pretty quickly. So that's a case of whiteout from mucus plugging. This is an example of,
The golden sign.
what?
A sign of golden.
What's this an example of, first of all?
Left upper lobe.
Right upper lobe atelectasis. Is this the S sign of golden? What is the S sign of golden?
It's right upper lobe.
Why do they call it an S sign? Actually, they call it the reverse S sign of golden, but why is it called that? It's caused by a mass, but what makes it an S sign? Why is this sign of reverse S sign of golden or not? Yes or no?
No,
Why not?
we don't see the nodular opacity from the mass.
Do you see a bulging in the fissure? With the reverse S sign of golden, usually when there's benign cause of collapse, the fissure is smooth. With the reverse S sign of golden, there's a bulging in the fissure because there's a central mass that's causing the obstruction. And the lung, the right upper lobe, and the fissure is not able to collapse against that central mass. So is that the case here?
No.
No. So this is a case of right upper lobe collapse. Now, could there be an endobronchial lesion? Yeah, there could be, but it's not the S sign of golden. Okay? So the features of right upper lobe collapse on the chest radiograph are, how do we recognize it?
Elevation of the right diaphragm.
Is this diaphragm elevated?
No. Elevation of the
Superior displacement of the minor fissure, opacity in the region of the right upper lobe here, the trachea is shifted over, which you can see. A very good sign on the chest radiograph of volume loss in the upper lobes, whether it's the right or the left, is what?
tracheal deviation.
Besides that. Elevation of the hilum, right? So the location of the left hilum versus the right hilum. What's the normal position of the left hilum relative to the right hilum?
That is higher than the right.
The left is usually slightly higher than the right. Can they be at the same level?
Yes.
Yes, occasionally it can be at the same level, but the right hilum should never be higher than the left. So to find the hilum, what you do is you find the interlobar pulmonary artery and you follow the trajectory back towards the mediastinum, right? And that trajectory tells you the position of the hilum. So this hilum is located here, this hilum is located over there. So that right hilum is slightly higher than the left. So elevation of the hilum is always a good sign for volume loss in the upper lobe, whether it's the right or the left. Okay? So that's the appearance of right upper lobe collapse. So the right upper lobe collapses upwards against the mediastinum. They all kind of look like this. They all look the same. Minor fissure elevated, opacity in the region of the right upper lobe, trachea shifted to the right, and the hilum is elevated. What are we looking at here?
Right middle lobe atelectasis.
So how do we recognize this as right middle lobe collapse?
Because on the lateral view, there's atelectasis of the right middle lobe and the lateral view.
What are the things that you're seeing on the chest radiograph that tell you it's right middle lobe collapse?
Looks like there's elevation of the right diaphragm.
What is this guy?
Left
Yeah,
fissure.
what about it? It's displaced inferiorly, okay? Another sign of pathology in the right middle lobe can be obscuration of the heart border. In this case, it's really not that obscured, okay? The lateral view here, also you can see the hilum is kind of sucked down towards that. The lateral view here is very helpful because you see what?
Opacification in the right.
What about the shape of the opacity?
It's abutting the minor fissure.
This
So-
shape is a triangular shape, right? So that triangular opacity overlying the heart border on the lateral view, right, is pretty good indication of something wrong in the middle lobe. Okay? And in this case, this turns out to be the minor fissure that is inferiorly displaced. So it's this clearly volume loss in the right middle lobe. It's an example of right middle lobe collapse, or right middle lobe atelectasis. So the right middle lobe collapses downward. It's sandwiched between the right upper lobe and the right lower lobe, and can give you this triangular shaped opacity, often on the lateral view, nicely, you can see that very nicely superimposed over the heart border. Here's another example. You have opacity here that obscures the heart border. Here it looks like pneumonia on the frontal view. When you look on the lateral view, though, you can see that triangular shape and the fact that the minor fissure is pulled down, so there's volume loss here in the right middle lobe. So this patient has collapse, atelectasis in the right middle lobe, and it involves predominantly this segment. What segment is that? Lateral segment of the right middle lobe. What about this case?
There's a right lower lobe opacity.
How do you know it's the right lower lobe opacity?
Since there's silhouetting of the right heavy diaphragm.
Okay, so the right diaphragm is silhouetted. Can you see the right heart border?
Yes.
Yeah, you can see the right heart border through the opacity. So what do you think this is?
Right lower lobe atelectasis.
What? Right what?
Lower lobe.
So what makes you think it's atelectasis and not pneumonia? So right lower lobe pneumonia and right lower lobe atelectasis can be very difficult to differentiate, right? You can't have both. You can have atelectasis and pneumonia. Remember, atelectasis means what?
Collapse.
Volume loss,
Volume loss.
right? So is there volume loss in the right lower lobe? Yes or no? Well, does that lung look smaller than the other side? Does the heart look like it's shifted towards the right?
Yes.
Yes, it does. So there is volume loss there. So at least some component of this is right lower lobe atelectasis. Okay, but it can be very difficult to differentiate right lower lobe atelectasis from pneumonia on the chest radiograph. You can also have the same problem on CT. In this case, on the CT though, we can see that it's clearly collapsed, right? Because here's the fissure displaced posteriorly. So we're looking at atelectasis there in the right lower lobe. Okay? So the right lower lobe collapses downward onto the diaphragm. And so that tends to obscure the diaphragm. Usually you can see the heart border go through the opacity of the collapsed right lower lobe. So is there volume loss here?
Yes.
How do we know?
There's elevation of the heavy diaphragm, and also there's been line shift towards the right.
Yes,
right
so
trachea.
is the heart shifted towards the right?
Yes.
Yes. So there's volume loss. Okay. So what's going on? What part of the lung is affected then?
Bronchus intermedius,
Why?
because there's there's a pacification of both the right lower lobe and right middle lobe lobes, because you have.
So how do you know this process involves both the right lower lobe and the right middle lobe?
Because there's silhouetting of the right heart border and the right heavy diaphragm.
Yeah. So that's very important. And if, by the way, does the lateral view confirm your suspicion?
Yes.
Okay, so what do you see on the lateral view that tells you this is right middle lobe and right lower lobe collapse?
Because because in the lateral view, the right middle lobe is opacified, and so is right lower lobe.
Well,
Well,
there's opacity going all the way from the
It's going-
front
yeah,
to
it's
the
going
back,
yeah.
involving the anterior part and the posterior part, and you clearly don't see the diaphragm.
Yeah.
Okay? So this is very important, and you're not going to get lateral views of these patients, because these are going to be patients in the ICU who get a portable chest radiograph. So if you're looking at a chest radiograph and there's volume loss, but you lose the right heart border and you lose the right diaphragm, then you have to consider combined atelectasis of the right middle lobe and the right lower lobe, and that tells us that the obstruction is
Bronchus intermedius.
bronchus intermedius, right? In this case, there's a mucus plug here. In the region of the bronchus intermedius, this is the collapsed right middle lobe, this is the collapsed right lower lobe, okay? And the rest of this represents compensatory hyperinflation here of the right upper lobe. Okay? So right middle lobe and right lower lobe will collapse down onto the diaphragm on the chest radiograph. You will lose the right heart border and the right diaphragm. In this case, what do we have? Is this normal or abnormal?
Abnormal.
Abnormal. So what would you describe as the abnormality? So why don't we start there? What's abnormal on this chest radiograph? Before you try to interpret what the cause is, what is it that you see that is abnormal?
Elevation of the diaphragm.
Okay, so the left diaphragm is elevated. What else is abnormal?
Sickle sign.
So you think that there's a lucency here, okay, which might be a loose sickle, right? What else is abnormal on the chest radiograph?
There's heart shift toward the left.
Heart may be shifted towards the. What about the heart, though? What is it about the heart that's important to notice?
Obscuration of the left heart border.
Yeah, the left heart border is obscured. You don't see the left heart border, right? Is there an abnormal opacity? Is there abnormal opacity on the chest radiograph?
Centrally in the left hilum.
Left hilum, yeah.
Yeah.
So, well, look at all this stuff, right? It's not normal to have all this opacity here overlying the left hilum, okay? So, is there volume loss?
Yes.
How do you know?
Elevation of the diaphragm.
Yeah, the diaphragm's elevated, okay? Do you think the hilum's elevated?
Yes, slightly. Yes.
Slightly, it's a tougher call, all right? Here's the lateral view. How do you interpret the lateral view?
There's opacity in the retrosternal clear space.
So there's opacity here in the retrosternal clear space, so what do you think is causing that?
Left upper lobe atelectasis.
So how do you know that's left upper lobe atelectasis?
There's compensatory hyperinflation of the left lower lobe and the fissures.
So, okay, so this line that you see represents what? That's the left major fissure, all right? So left upper lobe collapse can be very sneaky and very difficult on the frontal view. But on the lateral view, it's the best view to actually confirm it because you can see that the major fissure is displaced anteriorly, and then all of this opacity anterior to that represents the collapsed left upper lobe, okay? And then that was also from a mucus plug. They took out the mucus plug and everything goes back to normal. So the left upper lobe collapses upwards and towards the mediastinum. That's the appearance of left upper lobe collapse. Now, you mentioned something. What is it that you mentioned?
Yeah, the loose sickle sign.
You mentioned the loose sickle sign, okay? So now, before we get to the loose sickle sign, is there volume loss on this chest radiograph?
There's tenting of the left hemidiaphragm.
Yeah, there's some tenting of the left hemidiaphragm. Is there other evidence of volume loss on the chest radiograph?
The left hilum is severely.
Yeah, so the left hilum looks like, see, these vessels are stretched, the left hilum is elevated. We said that elevation of the hilum is always a good sign for
Left upper lobe.
where?
Left upper lobe.
In the upper lobe, okay? And does the left lung look smaller than the right?
Yes.
Is the heart shifted to the left?
Yes.
Yeah, all of these are observations that you need to be able to make on the chest radiograph. Because, I mean, it's easy to say, oh, he's going to show me a case of left upper lobe collapse next because that's the order we're going in. But when you're sitting in the reading room interpreting an x-ray that looks really funny, you have to sit there and ask yourself these questions. What do you see? What is abnormal? And how does that fit into my interpretation of what the overall pathology is on the chest radiograph, okay? So you said the sign was?
Loose sickle.
So what is the loose sickle sign?
Compensatory hyperinflation of left lower lobe.
First of all, what does loose sickle mean?
That's the German word for farming hoe or
Air, well, Luft means what? Luft is air, right? So it's a sickle of air. It's an air sickle, right? So there's this lucency alongside the aortic knob. This sign is associated with left upper lobe collapse, and you're telling us that that is caused by what?
Of hyperinflation of left lower lobe.
What, of what?
Of left lower lobe.
What part?
Compensatory. Oh, it's the apical segment.
Well, we call it there's no apical segment. It's the superior segment of the left lower lobe, right? So that's from compensatory hyperinflation, superior segment of the left upper lobe. So that's the Lupsical sign. Does the lateral view confirm that this patient has left upper lobe collapse?
Yes.
How?
Bulge, fissure, and retrocerebral passage.
Yeah, so again, we have this abnormal opacity here behind the sternum, and we have this interior displacement of the major fissure. Okay? So that's the Lupsical sign. And so this is the collapsed left upper lobe, this stuff here. This is the compensatory hyperinflation in the superior segment of left lower lobe. That comes up and becomes border forming with the aortic knob. And that's what gives you that area of lucency. Notice that it's located between the aortic knob and the collapsed left upper lobe. Okay? So that is why you have this. That's coming between the aortic knob and the collapsed left upper lobe, and that's what gives you the Lupsical sign when you have left upper lobe collapse. And this is the same patient. So this patient had a stenosis here in the left upper lobe bronchus, and the rest of this is just the collapsed left upper lobe. Okay? All right. So you should all be good at the game at this point. So what do we have here?
Retrocardiac opacity.
What do you think that represents?
Left lower lobe atelectasis.
How do you know? Besides, that's the only lobe left. But how do you know that's left lower lobe collapse? So again, the things that we look for. One, there's a retrocardiac opacity, right? So we see this, okay? Now, could that be pneumonia? Could that be a mass? What are the other things that you're going to ask yourself to decide that this is left lower lobe collapse?
It appears at the left, at the heart, it should shifted towards the left,
What is?
the heart.
Yeah, okay, so the heart looks like it shifted a little bit towards the left. We don't see the right heart border as far to the right of the spine as we usually do. What else? Do you see the left diaphragm?
No.
No, we don't see the left diaphragm. The left diaphragm is silhouetted here. Okay? What else? Left interlobar pulmonary artery is somewhat obscured. We don't see it very well. Okay, but this is characteristic. This triangular shape behind the heart border that obscures the diaphragm is the characteristic appearance of left lower lobe atelectasis. Now here's a lateral view, which you don't usually get on your patients. Okay, what's the abnormality on the lateral view?
Spine sign.
There's a spine sign, and what should you look for on? Always get in the habit of always looking for what on your lateral views. Looking for both diaphragms. You want to look for both diaphragms on the lateral view, right? Which diaphragm do we see here?
The right.
Right.
Yeah, so this is the right diaphragm. How do you know it's the right diaphragm that you're looking at here?
Inferior border of the heart goes below.
What's that?
The heart should sit on the left diaphragm, so if you see that diaphragm going.
Yeah, so you can see the diaphragm through the heart shadow. Usually the left diaphragm disappears because the heart is sitting on top of it. That's a natural silhouette sign. So here, the left diaphragm is completely obscured. We have this retrocardiac opacity. We think there's volume loss. That's the picture of left lower lobe atelectasis. Okay, so the left lower lobe collapses down onto the diaphragm and tends to obscure the diaphragm. This is what normal looks like in this patient. And again, it's very important when you think you've seen abnormality on the chest radiograph, bring up the prior studies, look at them, and see what did it look like before. So we should see the diaphragm in this patient. Now it's obscured, no opacity. Here's your retrocardiac opacity. And then the lateral view, that's what the normal lateral view should look like in this patient. You can see the right diaphragm through the heart shadow. The left diaphragm here goes anterior and disappears where the heart is. So this is what we're looking at now. So there's a spine sign, and that represents the collapsed left lower lobe that's obscuring this diaphragm, the left diaphragm. Okay? So it's the most common lobe where we develop or see atelectasis in patients in the ICU because secretions tend to go down there, and and fall down into the left lower lobe bronchus because of its dependent position. The wedge-shaped opacity behind the heart that obscures the diaphragm, heart shifted to the left, the typical appearance of left lower lobe collapse. Okay? There are 5 types of atelectasis. What are they?
Passive,
So obstructive is the most common, right? You mentioned
passive,
passive. What are the other types?
adhesive,
Adhesive,
Compressive.
compressive,
discoid.
cicatricial, right. Those are the 5 types of atelectasis. So let's talk about them. Obstructive, all the cases we've looked at so far are examples of obstructive atelectasis. When there's obstruction of the airway, the air goes out of the lobe that is obstructed, and so you get the collapse of the lobe and the volume loss. So that is obstructive atelectasis. So that's kind of what we've been looking at. What kind of atelectasis is this?
Passive.
All right, so this is passive atelectasis. So you can see that the lung here is completely collapsed, right? Here's the right lower lobe, here's the right middle lobe, completely collapsed. That's atelectasis, that's passive atelectasis. So our definition of passive atelectasis is what?
Atelectasis due to outside compression by another.
Not compression,
Not
but
compression,
due
but-
to
It's like massive.
mass.
Mass. Yeah, mass.
Where?
Outside of the. I guess like out
In
in the pleura.
the pleural space, right? So passive atelectasis is because that there's something in the pleural space that is causing the lung to collapse, right? Remember that if you have a patient who's intubated, okay, to get the air into the patient, the ventilator goes on. To get the air out of the patient, what happens? How does the air come out of the patient? Yes, the lung recoil. The ventilator doesn't have to do anything, right? So the natural tendency of the lung is to collapse. And what keeps it up is because you have that vacuum effect between the visceral and the parietal pleura, because there's nothing in the pleural space. Once you put something in the pleural space, especially a large amount of fluid, that recoil of the lung will cause it to collapse like this. So this is passive atelectasis. So the cause of the passive atelectasis in this patient is because the patient has a
Pleural effusion.
large right pleural effusion. Are we done with this case? Well, I mean, the natural question to ask yourself is what?
What was your
Why does the patient have a large right pleural effusion? Tell me.
Some small plaques, nodular thickening,
So what are you thinking?
could be asbestos,
So how do you know it's asbestos?
or it could be a tumor, such as.
Well, first you're gonna have to come down on one or the other, but has the patient had asbestos exposure?
Is to be determined in the history.
And what about on the imaging? Where?
Left.
There's a calcified pleural plaque on the left. Okay. What about on the right?
Yes.
There's a
There's a
smaller.
small
Yeah,
pleural plaque on the
there is
right.
calcified pleural plaque. So do we think the patient has had asbestos exposure?
Yes.
Yes. Can you have a benign pleural effusion from asbestos exposure? Yes or no?
Yes.
Yes, absolutely. Are you concerned this is malignant? You mentioned what tumor?
Mesothelioma.
So do you think this is mesothelioma? Yes or no? Or do you think it's benign?
Yes.
So why do you think it's mesothelioma?
Looks like on the second slice, looks like there's some chest wall extension.
Well, where do you see chest wall extension?
Kind of between the ribs,
Between the ribs?
to the chest wall.
No, the ribs look okay here. I mean, the pleura is thickened here,
Yeah.
but in this area over here, there's too much soft tissue. And it also looks like there's some thickening extending medially, but there's just too much soft tissue here. So you do have to be concerned that, you mentioned nodular pleural thickening. If you see any nodularity associated with a pleural effusion, you have to be concerned that it's malignant, and this was malignant mesothelioma in this case that was causing the pleural effusion. Okay? It's an example, though, of passive atelectasis from pleural effusion. So Is there volume loss on this, on the chest radiograph here within one of the lobes? Or more than one of the lobes? What do you think all this opacity is over here? Is that a pneumonia, or could that be something else? What about this opacity here?
So a large bullae.
Okay, so the patient has large bullae, all right? And so what do you think this might be? Why is it?
Compressive atelectasis.
All right, so there's, the bullae is pushing down, especially on the left lower lobe, okay? And so then we have compressive atelectasis. So the definition of compressive atelectasis is what?
Space occupying lesion in the lung.
Yeah, so space occupying lesion in the lung, so that's how you differentiate compressive from passive atelectasis, is compressive atelectasis. So commonly they're large bullae. This is sometimes the problem in patients with emphysema. They can have large bullae that compress the adjacent lung. You know, the bullae not functional, but the adjacent lung that is being compressed should be functional. So they can sometimes put in stents to try to get the air, to resorb the air out of the one-way valves, really, to try to get the air out of the bullae so that you relieve the compression on the adjacent lung, right? So that's compressive atelectasis. So that's a space-occupying process in the lung. Commonly, it's large bullae, could also be a large tumor causing compressive atelectasis. So here, where is their volume loss?
Right below.
Right upper lobe. Okay? So what do you think the cause of the volume loss is in this patient? Wow. So there's atelectasis of the right upper lobe. This is the minor fissure that's pulled up. How do you know it's cicatricial atelectasis? Yeah, it looks like there's bronchiectasis here, right? You see these tubular shadows up there in the right upper lobe. So what do you think the underlying cause might have been? Right, there's another sign also of volume loss in the right upper lobe besides the elevation of the fissure. What is it?
Rightward tracheal deviation.
Yeah, rightward tracheal deviation. Right? So those are, it's important to make those observations because you're looking for as much evidence as you can to support your interpretation. Okay. So what do you think the underlying disease was in this patient then?
Tuberculosis.
Tuberculosis, yeah, it's a common cause of scarring in the upper lobes, and it's a case of cicatrization atelectasis from tuberculosis in this patient. Okay? So other things that can do it, sarcoid, other fibrotic diseases. So normal or abnormal?
Abnormal.
Abnormal, what's wrong?
Looks like there is.
Well, first describe the abnormality. What's the abnormality?
So it looks like there's gradient.
Well, before we get to that, tell me what the abnormality is.
There's opacification of both hemithoraces.
What do you think those, how would you, is the opacities mass, effusions, what are you going to call them?
Atelectasis.
But before we get to that, okay, what are you going to call those opacities on the CT and the chest radiograph? We're going to call them what? Consolidations, right? There's extensive bilateral consolidations within the lungs, right? Now you made an observation about the consolidation on the CT. What was the observation that you made?
That is gradient dependent.
There's a gravitational gradient, right? So that the dependent portion of the consolidations are denser than the non-dependent portions. And what does that imply?
It implies diffuse alveolar damage / ARDS.
ARDS, right. And so if we're talking about atelectasis, then what kind of atelectasis is this?
Adhesive.
Adhesive atelectasis, which is caused by surfactant deficiency, right. So you can see the same thing in newborns, right, with the respiratory distress in the newborns. It's from surfactant deficiency, but it occurs in ARDS too. So that gravitational gradient helps you to say that this is a case of ARDS, and the opacities that we see here represent the lung collapsing on itself under its own weight because of the consolidation within the lung. Okay, so that's adhesive atelectasis from deficiency in surfactant. Right? So those are the different types of atelectasis. Now here's a pedian lateral chest radiograph. What's abnormal? When you look at these radiographs, is this normal or abnormal? At your usual normal indicating a viral chest radiograph?
No.
No, looks abnormal. So tell me, what looks abnormal on the chest radiograph?
There's elevation of the right diaphragm.
There's elevation of the diaphragm? Okay, so if anything, there's flattening of the diaphragm. Look at the lateral view, right? So these diaphragms are flat. There's flattening of the diaphragms. Okay, so what does that imply?
Hyperinflation.
Hyperinflation, right? So what do we think of the lung volumes?
Increased.
They're markedly increased, right? So this patient has hyperinflation and marked increase in lung volumes, okay? So if I told you the patient was a smoker, you would say what?
COPD.
COPD, emphysema, okay? But can we take this case a little bit further? Well, let's see. So does the patient have emphysema?
Yes.
Okay. How do you know?
There's bilateral apical bullae formation.
Okay. Well, these are not bullae.
No.
Right? These are areas of
It's
emphysema.
like central lobular emphysema.
Down here,
Bullae.
right? What is this?
Parabronchial thickening. Bronchiolitis.
That's bronchiectasis. Okay. So, what do we think is going on in this patient? What kind of emphysema do you think this is? There are different types of emphysema, right? What kind is this?
Panacenar.
Panacenar and panlobular. Why?
It's looks like it's not. Looks like it's also affecting the periphery as well as the central.
Well, the
lobular
most common
organs.
type of emphysema is what?
Central lobular.
Central lobular, which is caused by
COPD.
smoking.
Smoking.
Central lobular emphysema. You said this is panlobular, right? How do you differentiate panlobular from central lobular? On imaging. What is it about the distribution?
This is more basilar.
Okay, so it's worse at the lung bases. It's worse in the lower lungs than it is in the upper lungs. Is this worse in the lower lungs or the upper lungs?
Lower
It's
lungs.
worse in the lower lungs. So here you're suspecting then panlobular emphysema,
Mhm.
right? So what's the point of making that diagnosis? What causes that?
Alpha-1 antitrypsin deficiency.
Alpha-1 antitrypsin deficiency, okay? So that's what you, and if patients smoke, it actually accelerates the process, okay? So this is an example of what?
Central lobular emphysema.
Central lobular emphysema, right? So here you have these holes in the lung. What is this? This is paraseptal emphysema. So here the emphysema is predominantly in the periphery and also against the mediastinum, so it's paraseptal emphysema. Here also you have this large area of emphysema. What kind of emphysema is this? Well, what else is going on in the lung? Are there abnormal parenchymal opacities? Yes or no?
Yes.
Yes. Do you think this is neoplasm? Is that cancer? What are those opacities? What? What kind of bronchiectasis do you see?
Traction.
You said
Traction.
traction bronchiectasis. So what do you think we're looking at?
Fibrosis.
Fibrosis. Right? So there's traction bronchiectasis here associated with these opacities. By the way, what are these calcifications?
Calcified lymph
Calcified
nodes.
lymph nodes. What do you think the patient's underlying disease is?
TB.
Well, but-
Sarcoid.
yeah, I mean, it could be TB, but this was a case of sarcoid. All right? And then when we have large areas of fibrosis that might simulate masses, right, they can occur from TB or sarcoid, or we call that what?
The galaxy sign.
Well, the galaxy sign is a sign of it, but what is the process? Progressive massive fibrosis. Okay, so this is a patient with fibrosis. So that large air-containing lesion represents, so is that panlobular emphysema, central lobular emphysema, what is it? It's emphysema from scarring. Okay, that's cicatrization emphysema. So we can see emphysema, these large air spaces, also with scarring in the lung. They can pull on the lung and cause these areas of emphysema. Okay? So, definition of emphysema: abnormal permanent enlargement of the airways, right? And then the different types, we've kind of gone over what the different types of emphysema are. Panlobular affects the entire lobule, paraseptal, the periphery, underneath the pleural surfaces, centralobular, the central region of the lobule, centralobular emphysema, upper zone predominant, associated with smoking. Okay? So you have these holes. How do you differentiate emphysema from lung cysts?
Wall thickness.
Wall thickness, right? These have imperceptible walls. Cysts have thick walls or perceptible walls. So these are imperceptible walls, right? There's another very nice sign for emphysema, for centralobular emphysema, is preservation of the centralobular artery. So when you look at that hole in the lung, you can often find areas where there's a dot in the center, and that dot represents the centralobular artery, right? When you have cysts, you're not going to have that. So this is another nice way to confirm that you can hear about centralobular emphysema. And lobular is associated with alpha-1 antitrypsin deficiency. So it can give you diffuse regions of overall decreased lung attenuation from emphysema. Alpha-1 antitrypsin inhibits lysosomal proteases. And so if you're deficient in that, then the proteases run wild and cause emphysema. And of course, smoking will accelerate the process. So if you have somebody with alpha-1 antitrypsin who smokes, then their emphysema would be really bad. So this tends to be worse at the lung bases. So centralobular emphysema tends to be more extensive in the upper lungs. Panlobular emphysema tends to be worse at the lung bases. That's panlobular. And then paraseptal occurs in the periphery. This can be a cause of pneumothorax, especially in young adults. You can imagine if you have these peripheral areas of emphysema, can very easily rupture into the pleural space and can cause pneumothorax. So that's paraseptal emphysema. Differentiating paraseptal emphysema from honeycombing. Honeycombing, there are multiple layers. These have thick walls, and with paraseptal emphysema, there's usually a single layer here in the periphery. They're somewhat larger than the honeycomb cysts, and then you might find other evidence of emphysema, but not fibrosis, whereas with honeycombing, there will be architectural distortion and other signs of lung fibrosis. And then cicatricial emphysema, so we can see that in somebody with progressive massive fibrosis. It pulls on the adjacent lung, and that pulling results in these peripheral regions of emphysema. Okay? This patient has large areas of bullae here, right? And so if you have a young person who smokes and you see that the lungs are being replaced by these large bullae, there's a term for this. What is it called? Vanishing lung syndrome. Right? And so this is giant bullous emphysema or vanishing lung syndrome. So large bullae occupying at least 1/3 of any thorax, also paraseptal emphysema, tends to occur in young male smokers, and they'll get these large bullae in the upper lungs. So vanishing lung syndrome looks like the lungs are disappearing because they're being replaced by these large bullae.
If you look at this chest radiograph, what is the abnormality? How do we describe the abnormality here?
Lucent right lung?
Yeah, so this is called a hyperlucent hemithorax. So you notice that the right lung is more lucent than the left. So this is a typical radiology problem that comes up, and there is an approach to how we approach the hyperlucent lung. Right? So there is an organized, systematic way to go through the differential diagnosis. So that's what we'll discuss. So for this particular case, why is the lung hyperlucent?
Because there's a missing pectoral muscle.
Yeah, so there's absence of the pectoralis muscle. And what do we call this?
Poland syndrome.
Poland syndrome, right. So absence of the pectoralis muscle is Poland syndrome. But the first category of hyperlucent lung is abnormalities in the soft tissues. So this was the patient with Poland syndrome. You can see what the surface rendering there looks like. And that will cause that lung to look more lucent on the chest radiograph. In this particular case, we notice that the left lung looks somewhat more lucent than the right, especially down here. So why does this person have hyperlucent?
mastectomy?
Yeah, so this is a mastectomy. You notice that the breast shadow is missing on the left side. So that's an example of hyperlucent lung from mastectomy. And then here's the CT scan showing you the mastectomy in that particular patient. So the differential diagnosis for hyperlucent lung is organized into three categories. And the first category is abnormalities of the chest wall or the soft tissues. So that can be from rotation, from mastectomy, or Poland syndrome, which is congenital absence of the pectoralis muscle. Here's an example from rotation. So this patient is rotated left posterior oblique. What that tends to do is bring the soft tissues over the right chest, which makes it look somewhat more opaque. Remove the soft tissues, the overlying soft tissue from the left breast makes that look more lucent. Repeat chest x-ray with less rotation and everything looks normal. So even rotation can give you a hyperlucent lung. We already saw a case of a mastectomy, again a soft tissue abnormality that can give you a hyperlucent lung. And then Poland syndrome, congenital absence of the pectoralis muscle, so that also can result in hyperlucent lung. So another case where this lung is really lucent compared to the other side. So why does this patient have hyperlucent lung?
Pneumothorax?
Yeah, so this is a large, what kind of pneumothorax is this?
Tension pneumothorax?
Well, yeah, I mean, you wouldn't have to hesitate about that. This is a tension pneumothorax. So notice that the mediastinum is shifted away, absence of lung markings, the diaphragm is also depressed. Sometimes you can have depression of the diaphragm before you have mediastinal shift, but it's still a tension pneumothorax. So if there's any evidence of mass effect on that side because of the pneumothorax, then we would call that a tension pneumothorax. So here's a child, and we notice that the right lung is more lucent than the left. So what is the next thing that you would do in this case? If you're reading this case in the emergency room, what is the next thing you're going to do?
A right lateral DQ repeat,
So what are you thinking about here?
like a foreign body obstruction.
Okay, so here we have hyperlucent lung, but what makes you concerned about foreign body obstruction in this case when you're looking at the chest radiograph?
The right side expanded.
Yes, the right side is expanded. So in this case, you have increased volume here on the right side. You do see lung markings, so it's not a pneumothorax. So here in a child, you're worried about foreign body aspiration. And what do you expect to see on a right lateral decubitus view?
It stays inflated.
Stays inflated, right. Ideally, you would want to get expiratory views, but children are not going to be able to follow directions. So we do decubitus views, which simulates expiration on that side. Okay? So here's the right lateral decubitus, here's the left lateral decubitus. Notice in the left lateral decubitus view, the left lung does lose volume here, and so it should be smaller. The lung that is in the dependent position should be smaller. But here in the right lateral decubitus view, the lung stays expanded, increased volume compared to the left. So here you'd be concerned about foreign body aspiration. What about this case? Any thoughts here? So which lung is abnormal? What side is it?
The left?
Yeah, so the left side, there is some shift of the mediastinum towards the right. And the left side, there's some increased lucency here. When you look at the vascularity, there's a real paucity of vascularity here in the top and the bottom portions of the lung. So there seems to be some abnormality on the left side causing the shift of the mediastinum to the right. So again, we're thinking about air trapping, but what could be the cause? What could be the etiology? Well, here's the CAT scan in this case. So what do we see on the CAT scan? And what do we think is going on here? What's going on?
A large bullet.
Well, there are markings in here. You see vessels and you see markings in here. There is emphysema, right? Certainly it's hyperinflated. There is emphysema there. So what is this? What is going on in this patient?
Is it congenital lobar emphysema?
So what makes you think it's congenital lobar emphysema?
I think in the expansion and the appearance
Expansion of what?
of one lobe,
Which lobe?
left upper.
Yeah. And what's happening to the left lower lobe?
It's I guess compressed.
It's compressed, right. So here you have emphysema, but it's emphysema confined to an entire lobe. So the whole left upper lobe is hyperinflated and it's pushing on the left lower lobe. Hard to tell on the frontal radiograph, but there is emphysema here, right? There's hyperinflation here, the paucity of vascularity. It does seem to be pushing on the rest of the lung. So this is a case of congenital lobar emphysema. What's different about this case?
The left is shrunken, but it's abnormal. It's used.
Yeah, so this time the left lung is still more lucent than the right, and if you're not sure, you can look at the vascularity, and you see the vascularity here on the right looks normal, you see on the vascularity on the left is diminished. It's not a pneumothorax though, there's no pleural line, but this time, usually air trapping causes increased lung volume, but in this particular case, the lung volume on that side is decreased. So what are you thinking about here?
Swire-James.
So this is Swire-James syndrome. So small hyperlucent hemithorax is Swire-James syndrome. So what is Swire-James?
I think it's a congenital infection which causes.
Well, it's not congenital infection, no.
Oh, it's sorry, it's like a.
It could be usually a childhood infection. And what does it cause? Why is there air trapping?
So I think it's like.
It's like bronchiolitis. Yeah, right.
It's usually a viral infection that causes extensive bronchiolitis, which results in bronchiolitis obliterans, scarring of the small airways, and that causes the air trapping. But why is the lung small? Usually air trapping gives you a big lung. Why is the lung small? It's a childhood infection. The lung is small because it doesn't grow as much as the normal one. So this is something that we will see later on as the child grows. That lung does not grow as much as the normal lung grows because of the damage to the lung from the extensive infection. Actually, it's a bilateral process, but one lung can be affected more severely than the other lung, and that lung doesn't grow as much. And so you have a small hyperlucent lung. So small hyperlucent lung is the hallmark of Swire-James syndrome. So here you can see on the CT, again, look at the vascularity, diminished vascularity. The lung is smaller, hyperlucent. So this is a sequela of childhood viral infection from bronchiolitis obliterans, that is Swire-James syndrome. So we've gone through some causes. You have a question? Okay. So we've gone through some causes in that second category, increased air, which gives you hyperinflation, or air trapping really is what we're talking about, and that can give you a hyperlucent lung. So that can be from obstruction, foreign bodies, tumors, compression, small airway disease like Swire-James syndrome, congenital lobar emphysema, sometimes compensatory hyperinflation if there's obstruction or atelectasis on the other side, and then of course emphysema with bullae and pneumothorax. So these are things that result in air trapping. So tension pneumothorax, hopefully all of you can recognize that tension pneumothorax, so it shouldn't be much of a problem. We've discussed foreign bodies in children, which will cause air trapping on that side, and you want to get the cubitus views and to look to make sure that, or look to see if there's continued air trapping on that side. So that tells you that you're going to be worried about a foreign body. Congenital lobar emphysema, it's progressive hyperinflation of the lobe, usually in the neonatal period. Most commonly affects the left upper lobe, then the right middle lobe, then the right upper lobe. It's very rare in the lower lobes. And it's caused by dysplasia of the bronchus, which results in kind of a ball valve kind of obstruction. So the air gets in but can't get out. So the lobe gets progressively bigger and bigger because of the air trapping. So we saw a case of congenital lobar emphysema. So that's confined, that causes air trapping within an entire lobe. And then Swire-James syndrome, small hyperlucent hemithorax. Now, if I tell you that this patient is in ICU, and this patient has acute hypoxia, looking at the chest radiograph, what are you thinking in this case?
there a deep sulcus on the left, I think?
So when we compare the left lung to the right lung, there is some increased lucency on the left side, but you notice an asymmetry in the sulcus, left compared to right. So what are we concerned about here?
Pneumothorax.
Right, so here you're concerned about pneumothorax, okay? And so when we take a close view here, you can see the deep sulcus sign and you can see the pleural line. This is an example of pneumothorax, so that's the deep sulcus sign. Now there is a third category for hyperlucent. So here's an example of from the third category. Notice that this time the right lung, especially this area here, is somewhat more lucent than the other side. But so we've covered the first two categories, so soft tissue abnormalities, air trapping. The third category is what?
Vascular
Yeah, so
etiologies?
diminished vascularity, which causes the lung to be more lucent. So what would cause that in this case, and what sign is demonstrated here?
I mean, so there's decreased vascularity on the right. That could be from pulmonary embolism.
So the
but I don't
sign
know what
is-
the sign is called.
Okay. Who knows what the sign is? So when you have an decreased vascularity, which causes some increased lucency from pulmonary embolism, the sign is called
Westermark.
Westermark sign. Right, that is Westermark sign. So
Westermark.
Westermark sign. So pulmonary embolism. So decreased vascularity or decreased blood flow can also result in lucency, abnormal lucency, and a hyperlucent pneumothorax. So decreased blood flow or unilateral allodynia. So that is that third category for things that cause a hyperlucent pneumothorax. So what can give you decreased blood flow? PE, hypoplasia, pulmonary artery, stenosis pulmonary artery, hilar mass compressing pulmonary artery. All of these can result in allodynia. Okay, so these are the things that we've finished covering so far. Okay, so let's move on to small airway disease. We'll start with bronchiolitis. So the bronchioles are the small airways without cartilage. They're less than 1 millimeter in diameter. Membranous bronchioles are purely conducting. Respiratory bronchioles contain alveoli within the wall. So the respiratory bronchioli will have some alveoli there within the walls. Okay? Now bronchiolitis, when we get inflammation of the airways, okay, and if you get pus, and you can have tree and bud opacities from infected secretions within the airways, and that's a nice illustration of how you get a tree and bud pattern from bronchiolitis. So the bronchioles are located in the center of the secondary pulmonary lobule. They are centrilobular. The bronchial walls are less than 0.1 millimeters in thickness, and so they are not resolved on high-resolution CT. We do not see the normal centrilobular bronchiole on high-res CT because the wall is too thin. If there's a pathology, though, of the bronchiole, then it may be visible on CT. The centrilobular artery runs with the centrilobular bronchiole that we do see on CT as the dot within the center of the secondary pulmonary lobule. Now, there are signs of bronchiolitis that we can see on CT. The direct signs of bronchiolar disease, tree and bud opacities. That's when infected secretions plug up the centrilobular airways. Poorly defined centrilobular nodules. That's when we have inflammatory change, peribronchial inflammation, so kind of ground glass opacities around the centrilobular airways or the bronchioles. Bronchial wall thickening, that's less common to really see that on CT. An indirect sign on CT of bronchiolar disease is air trapping, and we'll get to that later. Now, tree and bud, you're all familiar with. Any infectious cause of bronchiolitis can give you tree and bud. Some of them are listed here. Poorly defined centrilobular nodules, so if we have centrilobular ground glass opacities without tree and bud, we can have that with inflammation that involves the centrilobular airways. We can see that with hypersensitivity pneumonitis. We can see that with respiratory bronchiolitis. And then the disease that gives you purely air trapping is constrictive bronchiolitis. Okay? So tree and bud from infected secretions within the bronchioles. So Normally, the bronchioles or walls are very thin. We don't see them on CT. But if you have impaction with infected secretions, then we can get these tree and bud opacities, and this we will see on CT, and that's what a tree and bud looks like. We'll see that later in the springtime. And then we're all familiar with what this tree and bud pattern looks like on CT, these branching opacities there on CT. And it results from secretions within these bronchioles, so kind of mucoid impaction or infected secretions causing impaction of these small airways. So we can see it with any infectious bronchiolitis. Make sure we consider tuberculosis and atypical infections, atypical mycobacterial infection, but we can see it with just about any kind of small airway disease. Here's examples of cystic fibrosis here, giving you tree and bud pattern. Now, if I tell you that this patient has recurrent Pseudomonas infections, and the patient is from Japan, notice the extensive airway disease, some tree and buds, what disease are we considering here? What do we call this? What disease gives you airway disease, recurrent Pseudomonas infections in the Japanese, in Japan? This is called, no takers,
Diffuse panbronchiolitis.
diffuse panbronchiolitis or Asian panbronchiolitis. So it's an unknown etiology. So it occurs in Asia, especially Japan and Korea, affecting middle-aged males, and they get infections, recurrent infections, sputum, bronchiectasis, extensive airway disease, and it can give you Pseudomonas infections and can be associated with sinusitis. And so only 30% 10-year survival, bronchiectasis, extensive airway disease. They can have large lung volumes as a result of air trapping from the airway disease. So the chest radiograph might show some air trapping there, but on the CT we will see the evidence of airway disease, pericardial thickening, bronchiectasis, tree and bud opacities. So the history and demographic information is very important in this case to make the diagnosis of Asian panbronchiolitis. All right, this should be pretty easy. What's the finding here? What are the findings?
Centrilobular ground glass
Right.
and air trapping.
Exactly right. Central lobular ground glass associated with air trapping. So your first thought here is going to be hypersensitivity pneumonitis. Right. So without tree and bud, we can see, especially if there's a ground glass central lobular nodules, we can get that with subacute hypersensitivity pneumonitis. You might also see that with respiratory bronchiolitis, although occasionally bronchiolitis from infection can also give you central lobular ground glass opacities without tree and bud. Rarer causes are also listed here. Respiratory bronchiolitis, we've covered this, associated with smoking. So these patients can also have central lobular ground glass opacities, so kind of very subtle central lobular ground glass, but of course smoking is the history that you are looking for, and if they have symptoms, we call it respiratory bronchiolitis associated interstitial lung disease. And then we'll have central lobular ground glass opacities, and of course that can get better if the patient stops smoking or if they're treated with steroids, as in this example here. Some other unusual causes of central lobular nodules, of course silicosis can do it. Here we usually don't get tree and bud though with silicosis. And then just when you kind of think you understand, you get a case like this. So then here we have a case of these kind of nodular opacities on the chest radiograph, and on the CT again, we see kind of scattered nodules. What is the distribution of the nodules here? What would you say the distribution is? Remember we talked about how we discussed distribution of nodules. So what distribution would you say this is?
Central lobular?
Yeah, so the first question we ask is what?
Is there, yeah.
What's the first question? When you're determining the distribution of nodules, the first question you ask is?
Does it involve the floor surface?
Yes, are the nodules touching the pleural surfaces? And the answer is no, as in this case, and that tells you the distribution is
Centrilobular.
centrilobular, right. Now when you look here, this kind of pattern of nodules. You see these kind of patterns of nodules. So what does that look like? What would you call that? What would you call that?
Tree and bud.
Tree and bud, sure. They look like tree and bud nodules. You kind of have these branching opacities, right? And then here on the CT, so yeah, these look like tree and bud nodules. Nice tree and bud nodules, right? But what is peculiar? What's kind of peculiar about this?
They look like they're continuous with the vessels.
Yeah, they're continuous with the blood vessels. So tree and bud, usually we talked about tree and bud nodules, right? So tree and bud nodules represent usually what?
Bronchiolitis.
Yeah, infectious bronchiolitis. So it should be continuous with what?
Airways.
It should be continuous with the airways. But these nodules are continuous with the blood vessels, not the airways. So what is going on here? What is this?
I don't know. So.
I don't know. Okay, well that doesn't.
Wait.
What could give you? So usually we think about tree and bud nodules as infectious bronchiolitis, nodules continuous with the airway. But what can give you a tree and bud pattern, except the tree and budding is caused by the vessels in the periphery? That these tree and buds are all continuous with the blood vessels. So something is going on with the blood vessels. What is going on with the blood vessels?
Like a lot of like microemboli.
Yeah, emboli, right. So emboli. So it could be emboli. Occasionally you might see this with tumor emboli. So you could have microscopic tumor emboli that gets into the vessels, the small pulmonary vessels, all the way into the periphery. That's usually kind of more localized, not as diffuse as this. When it's as diffuse as this, what should we think about as the cause? What is the patient doing? So this is called an excipient lung disease, IV talcosis, other terms, cellulose granulomatosis. So from its intravenous abuse of oral medication. So what happens is that they take the pills, and inside the pills, these are pills that are supposedly should be taken orally. There's talc as a binding agent and starch within the pills. But when they inject that intravenously, that talc and that binding agent, that's what embolizes to these small blood vessels here. And when it does that, it gives you these tree and bud opacities. So these are particulate emboli, which can be from this talc within the pills. And so they can develop an angiogranulomatous reaction, which accentuates the tree and bud pattern. Right? So this is called excipient lung disease or IV talcosis. But again, as I've said, tumor emboli can also be in the differential diagnosis if the tree and buds are continuous with the blood vessels and not the airways. Okay? Now, so we've covered these three, so let's move on down to here. Indirect signs of airway disease, and this is where we have air trapping here associated as the sign of the airway disease. Now, the first thing is any diffuse abnormality of the lung can be associated with air trapping. So there's an example of panbronchiolitis, sarcoid, chronic hypersensitivity pneumonitis. Any diffuse disease of the lungs can give you air trapping on expiratory views. So if you have air trapping on expiratory views in somebody with, underlying lung disease, it may not be that helpful as a finding because the diffuse lung disease can cause air trapping. So here, though, we're talking about air trapping as an isolated abnormality, okay? And then when we see that, then we think of small airway disease, bronchiolitis, affecting the very small airway. So the air trapping, of course, is easier to see on the expiratory views. So on the expiratory views, it can be subtle, but on the expiratory views, you can see the air trapping a lot better. So you want to do expiratory views if you're looking for this. And what happens with air trapping is that there's hypoxic vasoconstriction. So the blood is shunted to the more normal areas of the lung, which you can see a little bit of that here. But on the expiratory views, that's accentuated even more because the air trapping persists. So not only do we see lucency, but we see decreased size of blood vessels within the low attenuation region. Now there's a term for that. What is the term? When you have decreased perfusion, decreased blood vessels within these areas of lower attenuation, that is called mosaic perfusion. Mosaic perfusion. Okay? Now, any small airway disease can give you air trapping. Here's an example of asthma. The expiratory view shows you the air trapping. Okay? Chronic bronchitis, expiratory views show you the air trapping. So any small airway disease can result in air trapping. If I tell you, though, that this patient has a history of bone marrow transplant, notice inspiration doesn't look so bad, but we do have air trapping on expiratory views, and the patient is short of breath. What are we thinking about here? What is going on in this patient? So with that history of bone marrow transplant, why does the patient... Go ahead.
Microemboli.
No, it's not. It has nothing to do with emboli.
Drug reaction.
No, it's not a drug reaction.
This is graft versus host.
This is graft versus host disease. And what does it cause in the lung? What's the pathology in the lung? What is that called?
Bronchiolitis.
What kind of bronchiolitis?
Obliterans.
Bronchiolitis obliterans, right, or constrictive bronchiolitis. So what happens is that the bone marrow, the transplanted bone marrow, attacks the native lung and causes constrictive bronchiolitis or bronchiolitis obliterans, a small airway disease, fibrosis of the small airways, and that's what results in the air trapping. Okay? So constrictive bronchiolitis or bronchiolitis obliterans, this is what a normal bronchiole looks like. This is what happens when you get bronchiolitis obliterans. You get this fibroblast proliferation around the airways, and notice how it constricts and causes almost the obliteration of the airways, concentric fibrosis around the airways. That is bronchiolitis obliterans. So don't confuse that with BOOP, bronchiolitis obliterans, with organized pneumonia. Here the primary process is within the air spaces, and then you get these the granulation tissue that invades the bronchioles. Here, bronchiolitis obliterans is a fibrotic disease that affects primarily the small airways. Okay? So it's centered around the small airways. Now, what are causes of bronchiolitis obliterans? You can get it with lung transplant. Rejection of lung transplant is manifested as bronchiolitis obliterans as the immune system attacks the transplanted lung. We can't get this with bone marrow transplant, that's graft versus host disease. This time the transplanted bone marrow, the cells of the white cells or the immune cells of the transplanted bone marrow attack the native lung. That's graft versus host disease. Swyer-James syndrome is post-infectious bronchiolitis obliterans. So we've seen that toxic fumes, cytophilia disease from nitrous oxide, that can also cause bronchiolitis obliterans. There are some other more miscellaneous causes also of bronchiolitis obliterans. So after transplant, it can occur after heart-lung transplant or lung transplant. 50% of patients after lung transplant can develop bronchiolitis obliterans between 6 months and a year as a manifestation of rejection. So these patients are followed with pulmonary function tests to see if they're developing any obstructive physiology, because that's a sign of rejection, and they will get progressive dyspnea. After bone marrow transplant, we've talked about graft versus host disease. This can occur anytime after 3 months after bone marrow transplant. You might see air trapping, increased lung volumes with constrictive bronchiolitis. On CT, the manifestation is air trapping. So mosaic attenuation, you want to make sure you do expiratory views. What happens is that the blood is shunted away from the areas of the lung where there's air trapping. So there are 2 reasons for the lung to look more lucid. One is the air trapping. The second is that the blood flow is shunted away, which is why we see mosaic perfusion. We see that the blood vessels are smaller within the areas of more lucent lung. And then you want to do expiratory views to show that. Okay? So air trapping on expiratory stage. You might also see mild bronchiectasis in these cases. So we look for mosaic attenuation and really mosaic perfusion with bronchiolitis obliterans. We might have mild bronchial dilatation. We look for air trapping on expiratory views. Okay? So the most specific signs for bronchiolitis obliterans, bronchial dilatation within the lower lobes associated with air trapping. So on expiratory views, we see the air trapping, and we see some parabronchial thickening, mild bronchiectasis. So these are the classic findings of bronchiolitis obliterans. A number of years, fairly recently, maybe about 10 years ago, this came up, and there was a settlement that was made actually between popcorn makers and the people working within the factory. So there's a ketone that's used for flavoring of microwave popcorn. So this chemical within that resulted in bronchiolitis obliterans for these patients who worked in the factory. So you can see some air trapping and expiratory view, and that was called flavor workers' lung. Flavor workers' lung from working in a popcorn factory. Okay? Now in this case, which lung is abnormal? Well, is there anything abnormal here?
The right lung, I think.
Well, what do you think of the mediastinum here?
It shifted towards the left.
It shifted towards the left, yeah. So which lung is the abnormal lung? The right lung or the left lung?
Okay, let's say the left. There's volume loss maybe on the left then.
Now, but what will you look at to confirm your suspicion that there's something wrong with the left lung? What should you look at? Look at the vascularity. What do you notice when you compare the vascularity of the right lung to the left lung?
It's diminished on the left.
It's diminished on the left, so which lung is abnormal?
The left.
The left.
The left. What's your diagnosis? Well, which lung is more lucent?
The left lung,
Why are you asking that as a question?
and then
And which lung is smaller?
the left lung.
So what's the diagnosis?
Of Squire James.
This is Swire-James. Yeah.
Okay.
So you have a lucent lung, and then this time it's diminished vascularity, right? But it is more lucent, but it's smaller. This is Swire-James syndrome. Now, Swire-James is a bilateral disease. Notice that there is air trapping bilaterally here, okay? But the lung that is affected more severely does not grow as much, so that is the smaller lung. Small hyperlucent lung, Swire-James syndrome. This is a sequela of bronchiolitis obliterans from childhood infection, usually adenovirus. Okay? So that's what bronchiolitis obliterans, that's what Swire-James is. Now, what is abnormal here when we look at the lung windows in this case? What's abnormal here? Well, is there mosaic attenuation when you look at the lung breaker? Yes or no?
Yeah, a little bit.
A little bit.
On the left, on the right lower image, and on the upper one, too. Yeah.
Okay, and now when you look at the blood vessels, what do you notice about the blood vessels when you look at the areas of lower lung attenuation compared to the areas of higher lung attenuation? See? So look at the blood vessels here, right? That's lower attenuation compared to here, right?
Yeah.
So when you look at that, look at the blood vessels here compared to here. Okay? So what's different about the blood vessels when you do that?
They're bigger in the regions of higher attenuation.
Yeah, now remember we said, so there is mosaic attenuation, but we said there was a more specific term to use in this particular case when the blood vessels are smaller in the lucent regions. What was that more specific term?
Mosaic perfusion.
Mosaic perfusion, right. So here we have mosaic perfusion, right? So you see the blood vessels are smaller within the areas of lung of infusion. It almost looks ground glass, right, here, compared to these areas. Now, we've seen cases of mosaic perfusion most commonly is associated with air trapping from airway disease. Is that the case here? Is this mosaic perfusion from airway disease? Or is this something else?
Something else?
Why? Why is this something else? And what is this something else?
Well, I don't see any.
You don't see any what?
I'm looking for chronic pulmonary embolism.
You're not going to see it on the lung windows, right?
Exactly.
Well, what will you see on the lung windows? What?
I can't say it's that, but yeah, but the vessels are large. Like, the arteries are very large.
What part of the arteries are large?
Like the segmental, subsegmental, and like everything. Yeah? Like a lot of.
No. The central pulmonary arteries. Okay? So the central pulmonary arteries are really big, right? So what would cause that?
Pulmonary hypertension.
Pulmonary hypertension, right. So if you suspect pulmonary hypertension in a patient with mosaic perfusion, the most common cause is chronic pulmonary embolism, right. And so now we looked at the CTs with some contrast and these soft tissue windows. So is there evidence of chronic PE in this case? First of all, does the patient have pulmonary hypertension? Yes or no?
Yes.
How do you know?
Yes.
How do you know? How do you know the patient has pulmonary hypertension?
Pulmonary artery is bigger than the aorta.
Well, what is supportive evidence? What other supportive evidence would you look for?
Large right ventricle.
So what else about the right ventricle?
Also, interventricular septum a little bit to the left ventricle.
What else about the right ventricle?
There's myocardial.
There's what? Myocardial
hypertrophy.
hypertrophy. So the right ventricle is dilated. By the way, what about the right atrium? You notice about the right atrium. It's also dilated, right? So you have enlargement of the right ventricle with right ventricular hypertrophy. What does that tell you? It tells you, what does it tell you?
There's increased resistance.
There's increased pressure. Where?
Yeah. At the outflow of the right ventricle.
In the right ventricle.
Okay, yeah.
You could say that there's increased pressure in the right ventricle. You have dilatation of the right ventricle, you have hypertrophy of the right ventricle, so the right ventricular pressures are elevated, right? So you would assume then that the pressures are elevated because of pulmonary hypertension, right? So, by the way, why is the right atrium dilated? Why do you have dilatation of the right atrium?
Increased pressure.
Increased
Also,
pressure where?
in the right ventricle and then the right.
Well, wait a minute though. There's something that prevents the right atrium from seeing the right ventricular pressure. What is that?
So the valve.
What valve?
Tricuspid valve.
The tricuspid valve. So why does the right atrium dilate?
Stenosis of the tricuspid valve. Then?
No, you were doing well until that.
Okay.
How do they, on echocardiography, remember, they can give you an estimate of the pulmonary artery pressure, right? You've seen that in the echocardiography reports, yes?
Yeah.
How do they do that? How can they possibly tell you what the pulmonary artery pressure is from an echo? You never wondered? You see that in the reports, you never wonder, my goodness, how do they do this? So how do they do that?
They calculate the velocity across the tricuspid valve
They calculate the velocity of what?
of
Of what? Can't hear you. Speak up. They calculate the velocity of what? I hear a lot of mumbling, but no answers. They calculate the velocity of the tricuspid regurgitation. Okay? The velocity of the tricuspid regurgitation tells them what the pressure gradient is between the right atrium and the right ventricle. The pressures in the right atrium are usually pretty small. And so that tells you the relative pressures are in the right ventricle, and you assume that those are the pressures of the pulmonary artery. So that's how they estimate the pulmonary artery pressure. So what happens is when you develop increased pressures in the right ventricle, the tricuspid valve is not very good at handling that. You get tricuspid regurgitation. And then the velocity of that tricuspid regurg gives them an idea of what the pressures are within the right ventricle. That's how they do that with the echocardiography. Now going back to this case, does this patient have evidence of chronic pulmonary embolism? Yes or no? Well, what would you look for? I hear crickets.
Filling defects.
Where? Do you see any?
Yeah.
Where?
Interlobar on the left.
Okay. So on the left, looks like there's an eccentric filling defect here. Anything abnormal on the right? What is this? See what I'm pointing to? What is that?
It's a web.
That's a web. Okay. So what does a web indicate?
It's a chronic E.
Yeah, it's recanalization. That's also a sign of chronic PE. So here on the reformatted view, you can see the eccentric filling defect here in the left interlobar pulmonary artery, and then here's the web on the right. So webs are also signs of chronic PE. Here's another more dramatic example of mosaic perfusion from chronic PE. This time you can really see the eccentric filling defect there on the right, and here it is also on the left. Okay? So, mosaic attenuation is when we have patchy areas of increased and decreased lung attenuation on CT. Mosaic perfusion is when the blood vessels are decreased in size and number in the lucent areas because blood flow is diverted away, also called mosaic allogemia. Air trapping, that's on expiratory views. We look for accentuation of the lucent areas. That's air trapping. Okay? So mosaic perfusion, the most common cause of mosaic perfusion is air trapping, but a less common cause is vascular disease like chronic PE. Occasionally vasculitis can also do that, but chronic PE is the most common vascular cause of mosaic perfusion. Now mosaic attenuation can be caused by infiltrative disease. If the ground glass is infiltrative disease like pneumocystis pneumonia, or small airway disease, that's when we have air trapping, or vascular disease. We saw some cases of chronic pulmonary embolism and pulmonary artery hypertension. So if we have diffuse ground glass, like you might see with pneumocystis infection, right, that can give you mosaic attenuation, but here the blood vessels would be preserved also in the more lucent areas. And if you do expiratory views, you should not see air trapping, okay? As opposed to small airway disease. So here we do see the mosaic perfusion, the smaller blood vessels, and then on expiratory views, the air trapping is accentuated. And then we saw cases of chronic PE, which can also give you mosaic perfusion. Now, differentiating mosaic perfusion of chronic PE from air trapping, usually here, it follows a vascular distribution, the areas of lower attenuation Whereas when you have air trapping, you can often see lobules. You see these lobular regions of air trapping. So it follows more of a lobular distribution if you have air trapping. See that? Follows a secondary pulmonary lobule, okay? As opposed to this, which is more vascular in distribution. So if you have big pulmonary arteries, of course, and mosaic perfusion, you're going to think of pulmonary hypertension and chronic pulmonary embolism. And then I've given you this little chart of everything. It's kind of a review of everything we've already gone through for how we approach mosaic attenuation. So if you have mosaic attenuation, you look at the size and number of blood vessels throughout the lung. If they are preserved and you think of infiltrative diseases, then the ground glass you're seeing is abnormal, so pneumocystis pneumonia or some other things that can do that. If there's air trapping on expiratory CT, then we think of airway diseases like bronchiolitis obliterans, okay? If there is no air trapping, then we think of vascular disease like chronic PE that is causing the mosaic perfusion. Now, that's the blueprint, but in real life, things get a little bit more complicated. So in real life, you have to realize that air trapping does come up quite a bit, and it may actually be normal. So chronic PE can sometimes be associated with air trapping, which goes against what we're usually taught. Here's an example of that. Acute PE sometimes can be associated with air trapping. So in real life, things get a little bit more complicated. And then even normal patients can have regions of air trapping on CT. In this study, 38% of non-smokers with normal pulmonary function tests had air trapping when they did expiratory views on CT. So they can have extensive air trapping. Even normal patients sometimes who are asymptomatic can have extensive air trapping. So what does this mean? Well, for your exams, the party line, significant air trapping on expiratory CT is abnormal, and so think of small airway disease. So think about COPD, asthma, bronchiolitis obliterans, if you have air trapping on expiratory CT for your exam. But in real life, because CT can be very sensitive to air trapping as an isolated finding can be problematic. So you need to correlate with symptoms and clinical history. So just because I see air trapping in a normal patient or in a patient on a CT scan does not mean that that is pathologic. So you have to remember that. So correlate with symptoms. Were there any signs of shortness of breath in this patient? Were there any other things in the clinical history, like if we're looking for constrictive bronchiolitis, is there a reason we would be looking for constrictive bronchiolitis in this particular patient? These are all things to think about. So patients who are asymptomatic and otherwise normal can demonstrate air trapping. So you have to be careful with air trapping as an isolated every now and then. Okay? Any questions?